in this part we are going to start talking about the channelopathies. Okay. Every time we talk about channelopathies, we must say that the problem is, as it says, in a channel. Okay. Usually what happens is that we have a gene that codifies a protein, and this protein is part of any of the channels. And when we find a channelopathy, sometimes we can find the problem as a mutation of the gene. It is really good when we find this mutation in the gene because it gives us a lot of diagnostic value, a lot of prognostic value, and also it allows us to go and study the family of the patient. But the problem is that it is not always possible to find the mutation of the genes. So it gives us the chance that there are different channelopathies have different genetic diagnostic yield. We are going to have some channelopathies that have high genetic diagnostic yield, and other ones that are going to have less diagnostic yield, depending on the probability that we are going to have on finding a mutation for them. So we are going to begin with the first syndrome. That is, the first one will be the Brugada syndrome. Well, the Brugada syndrome has a diagnostic yield relatively low. The genetic diagnostic yield is 20 to 25%. So when we find a patient with Brugada syndrome, the probability of identifying the mutation in the gene is about 20 to 25. Then, which genes are usually involved? Well, most of the time we are going to find that the problem is the SCN5A that codifies the alpha subunit of the protein of sodium. So when we remember Brugada, what we must remember is that the problem is usually in the channel of sodium. We must remember sodium when we think about Brugada syndrome. We can find other genes that could be involved, that is the SCN1B, SCN2B, and 3B. All of them codify the beta protein of the sodium channel. So what happens here in the Brugada syndrome is that only some cells, usually located in the outflow tract of the right ventricle, have an impaired function of this channel, this sodium channel. So when they open and they start the action potential in phase 0, it happens that they start opening but very slow, so they have the slope is smaller than usual, and it's not only smaller, it happens that also because the potassium, the transient potassium channels, the ITO potassium channels is still pushing down the action potential, they are not going to reach the complete depolarization, so they will keep in here. So in the end, what we are going to have is a small complex in Brugada syndrome. And because we are not going to reach this 0, we could have that here, meanwhile, when we're still in phase 2 or phase 3, some sodium channels could still be open and produce what we have seen before, early after depolarization. And it is a problem, as we know. So, what are we going to find in the ECG? Usually we are going to find the problem in V1 and V2 in the surface ECG, because those are the leads that are in front of the outflow tract of the right ventricle. So I'm going to draw a QRS complex from the V1 or V2. So we have the P wave, we have the small Q, R, a big S, like U1, and then what happens is that meanwhile in the cells that are affected in the outflow tract, we are going to have this complex. In the other cells, we are going to have a normal complex. So we are going to always have a gradient between them. It means that we are never going to have a normal ST. The ST will always be elevated. Always be elevated when we have this shape. It will go down, and then we'll have the T wave. So this is the usual shape of the QRS in the Brugada syndrome, usually assessed in V1 or V2. This is the type 1. This is what is called the type 1 Brugada complex, and it's the only one that is diagnostic. We could have other types of Brugada, which are minors. Like could be the type 2, where I'm going to have an elevation, but more discrete elevation. We need at least 2 millimeters in height here to be diagnostic. And then it will be type 2. And then we could also have type 3, in case we have this similar shape but with less than 2 millimeters. The only diagnostic one is type 1. We will need type 1 shape of the V1 and also some other clinical features, like for example unexplained syncope or some family relatives, or the documentation of ventricular tachycardia to diagnose a person with type 1 Brugada. Sometimes we are going to have type 2 or type 3 that are diagnostic, but we could also have the situation in which we have a patient who is suspicious of having Brugada syndrome, and we have the type 2 or type 3, and it happens that he has a hidden pattern. And we can try to unmask this hidden pattern of type 2 or type 3 and try to turn it into type 1 by adding a drug. Drug that could be either prokinamide or agemalin. Those are, as we will see later on the anti-arrhythmic drugs, those are drugs that usually block the sodium channels. And if we have a pattern of type 2 or of type 3, we can try to unmask this pattern by giving one of those drugs, and then it will turn into type 1 if the patient actually has Brugada syndrome. An optional treatment for Brugada syndrome will be quinidine. Quinidine is a blocker of sodium channels, but it is not the main function of the drug, because the blocking of sodium channels is very weak. The main function, and that's why we could give it in patients with Brugada syndromes, is because it blocks the transient potassium channels. Those were the ones that bring down the action potential in patients with Brugada, and that is why it is an optional treatment. Although most of the patients are going to have to receive the defibrillator. The next syndrome is the long QT syndrome. long QT syndrome. Here, the genetic diagnostic yield is higher. Fortunately, can lead to up to 85% of the patients we are going to be able to find, to identify a mutation in the genes. Which are the genes that are usually involved? Well, here we have a lot of types, up to 19 types of long QT syndrome. And here we are going to describe only the three that are more frequent, type 1, type 2, and type 3. Okay, usually type 1 is codified. Type 1 is codified by the gene KCNQ1. Okay. This usually codifies this, the protein of this channel, the IKS potassium channel. Because this channel is impaired, usually what happens is that when we arrive here to the phase 3, because if this impaired, it's going to be prolonged, and the refractory period will prolong, and the QT will also get prolonged. So if we draw here the type 1, we'll have the P wave, the QRS, and usually we have a prolonged QT with a very wide base T wave. Okay. Here to explain why this is dangerous, we need to know what is the action of catecholamines. If we give catecholamines to a patient, what they do, we have said before that if we give catecholamines, they are going to increase both calcium and sodium in the pacemaker cells, so they are going to increase the heart rate, but they will also put more calcium here, so that more calcium enters and the heart can contract with more strength. Have what is called the positive inotropic effect. They managed to do this by increasing those channels, but what they usually do, the catecholamines, is that they usually increase these channels so that in the end we can have more calcium inside the cell without widening the action potential. So what happens here is, because this channel is impaired, if we give catecholamines to a patient with a long QT syndrome, they will put more calcium inside, but they are not going to be able to put more potassium outside. So in the end, it will prolong the QT. So for patients with this type 1 long QT, catecholamines are not good. So usually those patients have problems with exercise. With exercise, they are going to have arrhythmias. So what are we going to give to those patients? Usually the beta blockers are good for those patients. We are going to give beta blockers to avoid these catecholamines. What happened with type 2? Type 2 long QT syndrome is codified by another gene, that is the KCNH2, that codifies the other one of the rectifies potassium, delayed potassium channels. So it's the IKR. It's pretty similar to this one because we also have problem with the catecholamines because they have the same problem. But the thing is that here the arrhythmias are usually triggered by emotions. Well, the beta blocker, we also give beta blockers to these patients, although they are not as effective as with type 1. So we are going to go to the type 3. Type 3. The type 3, well, how are we going to see in the surface ECG the type 2? Type 2 will be diagnosed by a prolongation of the QT, but in that case we are going to have a bifid T wave. Well, let's see type 3. Type 3, usually the problem is in the gene SCN5A. You will remember this because it's the same gene as we have here in the Brugada syndrome, but here the problem is the opposite. Here we don't have an impaired sodium channel problem. Here we have an enhanced sodium channel. So what happens here? Usually that because the sodium channel are not going to close in this part, we can easily have early after depolarization in each part because of those sodium channels are not going to close during this refractory period. So, because we are going to have early repolarization, in this case, as we know, the problem with early repolarization is that they become more frequent when we have low heart rate. So these patients usually trigger the arrhythmias during sleep. Of course, in these patients, beta blockers are not going to be very effective. Sometimes we give a blocker of sodium channels that do not increase the refractory period that we will see in the anti-arrhythmic drugs part, that is called mexiletine. Mexiletine is an anti-arrhythmic drug that block the sodium channels and avoid those spikes and do not prolong the refractory period because it is already prolonged. How are we going to see it in the ECG, in the surface ECG? We are going to see the type 3 also as a prolonged QRS, but in that case it will be a very long ST and a small t at the end, but also it's going to be prolonged. So after that we are going to go for the next syndrome, that is the short QT syndrome. Here, what? Okay, we have that it is just the opposite of type 1 and type 2. Here we have the other way around. So type 1, this is much less frequent than the long QT syndrome, but it is very, very, very dangerous, even more dangerous, that has higher mortality than the long QT syndrome. This type 1 here will be codified by the one that is codified in type 2 long QT, so it will be the KCNH2 that we know that codifies the IKR. And the type 2 will be by the KCNQ Q1 that codifies the IKS. Here, the problem will be just the opposite. That in that case, usually what happens is that those channels are enhanced, so they release more potassium more rapidly, and what they do is that they shorten the repolarization. The problem here is that we have a shorter refractory period, and we can also have arrhythmias. Finally, we will talk about a little bit about another syndrome that we have already mentioned, that is called the CPVT, catecholaminergic polymorphic ventricular tachycardia. Here is a problem in which a gene that codifies the ryanodine receptor that we have in the sarcoplasmic reticulum, the ryanodine receptor, has a leak in calcium. So, as we know, calcium will be released during this phase 4. And if we reach the threshold, we are going to have after depolarization. In that case, usually delayed after depolarization. So, as we know, it will be an entrance of calcium, and the main treatment will be, in that case, because we want a drug that slows the heart rate, but because we know that in delayed after depolarization, if we have a high heart rate and a longer action potential, it will be more of those spikes. Then we need a drug that do not prolong the action potential, and also that decrease the heart rate. So usually beta blockers are going to be the treatment of CPVT. As we will see, we can also give other drugs like flecainide, because they have also shown to block this ryanodine in the sarcoplasmic reticulum. So, as a summary for the Channelopathies, we could say that we can have the Brugada syndrome. Here, the main problem is in the sodium channels that are impaired. Usually what we could do, most of the patient will receive a defibrillator, but we could use quinidine, for example. We will see in the anti-arrhythmic drugs, because quinidine is a blocker of the transient potassium channels that are the ones that are responsible of breaking down this action potential. Then we'll have the long QT syndrome. For long QT syndrome 1 and 2, we are going to have the problem in the potassium channel, those potassium channels here, and for those, beta blockers will be at least moderately effective. And then we'll have the type 3. Here the problem is with the sodium channels that are enhanced, and here beta blockers are not going to be effective. We will need to implant a defibrillator, with or without the addition of mexiletine, as it is a sodium channel blocker without QT prolongation. Also, the short QT syndrome. In this short QT syndrome, we have the problem is that is an enhanced potassium channels. Those potassium channels here we don't have any drug that is considered effective. Most of them will receive a defibrillator. And finally, we have the CPVT. The problem is here, the ryanodine receptor. The problem here is calcium. So here, beta blockers will be effective by the way that we have told before, through blocking mainly the beta 1 receptors of the catecholamines. Thank you.